Hello and welcome to the second lecture in the Understanding the ECG lecture series. My name's Fielder Cam and I'm a cardiology registrar, and today we're going to be talking about ischemia and infarction and how that relates to the ECG. So our learning objectives before we go any further. One is to describe the cardiac vascular territories and how they're related to the ECG. Second is to understand the development and timescale of ECG ischemic changes. 3, recognize the ECG features of ST elevation and non-ST elevation myocardial infarctions. That's obviously a very key point for both clinical practice but also medical school examinations. 4 is to try and get an understanding of why ST elevation and depression occurs. 5 is to understand the development of Q waves and why they are important, because they're talked about a lot, and I think a lot of people don't necessarily know why they come about. And the final part of our learning objectives is just to have an idea of the common mimics for ischemic patterns on the ECG. So before we get into the real meat of the lecture today, and this is something that we'll be doing for every lecture moving forward, is we're just going to recap how to read the ECG. If you need more detail, then I'd suggest going back to lecture 1 and revisiting it, but here we're just going to take a very quick whistle stop around the interpretation of the ECG. So we should start our interpretation by going through the details, the name, age, date, and hopefully indication for the ECG, confirming whether the ECG is calibrated correctly, looking at the ventricular rate, then the rhythm, and particularly whether we've got P waves preceding each QRS, and whether those P waves are upright in lead 2 to suggest that it's sinus rhythm, what the overall cardiac axis is, remembering that leads 1 and 2 are probably sufficient to do that, and then moving on to the waves and segments themselves. So you've got your P wave, your PR interval, your QRS complex representing ventricular depolarization, your ST segment, and then your T wave, and then after that your QT interval. And if you're unsure about how you should be interpreting these things, then I would recommend going back to lecture 1. So let's start with some definitions. The first is ischemia, which is a restriction of blood supply to a tissue leading to a shortage of oxygen. And the other is infarction, which is actually tissue death resulting from that lack of oxygen supply. So you can often have ischemia without infarction. And a STEMI, this is a full thickness infarct of the myocardium. So within a certain area of the heart, all of that muscle from top to bottom has died, and that presents with ST elevation on the ECG. And that compares with a non-STEMI or an NSTEMI, which is a partial thickness infarct of the myocardium. Normally it's the subendocardium that infarcts most easily, and that presents with other ECG features. Prominently, potentially you have just T wave inversion or ST depression, but often you can have no ECG features at all. So I think it's important to have an idea of some of the vascular territories around the heart. So the heart is supplied by a left and right coronary artery that comes off the aorta, and then that left coronary splits into the left anterior descending and the circumflex arteries. And so our left anterior descending is here in green, and that, as the name suggests, comes down the anterior portion of the left ventricle, and that tends to serve the anterior wall of the left ventricle and the anterior 2/3 of the intraventricular septum, and that's the sort of green area here. And on the ECG, we tend to talk about that as being the anterior and septal regions. Blue here is our left circumflex artery, and that comes round the lateral surface of the left ventricle. And then our right coronary artery here in red comes round and for our purposes essentially deals with the inferior portion of the heart, and it's certainly picked up most on the inferior leads of the 12-lead ECG. And so how does this relate to our leads? Well, if we take our chest leads and we cut the heart through in our axial plane as we did in lecture 1. We have V1 and V2, which are our septal leads, and they're looking pretty much at the LAD territory. Certainly by the time we get around to V3, V4, we're really looking at the anterior surface. And so that's still LAD territory. And then V5 and V6 are our lateral leads, and they're looking at that lateral surface of the left ventricle. Remember, V6 is in the mid-axillary line, so it really is right round to the side of the heart, and that's serving the circumflex territory there. And so if we move on to our limb and augmented leads here, and we cut the heart through in our coronal plane, we can see that 2, 3, and AVF are looking at the inferior portion. I think it's important to realize that that red coloration on the heart really folds right underneath onto the inferior section there, so that lead 2 on this diagram, I appreciate, looks like it's looking at the green anterior septal territory, but actually it's looking right underneath the heart at what would be an extension of that red territory there. And then we've got leads 1 and AVL, which really look on this lateral surface here, and they're dealing with circumflex territory. And you'll probably notice that AVR is the only lead I haven't talked about, and that's because it really looks from this right upper region and doesn't really look at any areas that are sort of truly representative of a vascular territory. So how do these vascular territories plot onto our standard 12-lead ECG here? You can see in green we've got V1 and V2, which are our septal leads, and V3 and V4, which are our anterior leads. And then the lateral leads here are slightly more stretched apart on the ECG, so you've got 5 and 6 together there, but 1 and AVL are a bit more dotted around. And that's probably worth remembering, that if you're worried about the lateral territories, you really do need to look at AVL and 1 as well. And then our inferior leads are grouped together here at the bottom left of the ECG, so that's leads 2, 3, and AVF. You can see again that AVR has been sort of uncoloured in this diagram. So, ST elevation. If somebody's having an ST elevation myocardial infarction, the ECG changes that you get occur over a pretty standard period of time. And so beforehand, you have a pretty normal looking ECG here. So you've got flat ST segments and an upright T wave. And then within minutes to up to 8 hours, ST elevation develops. And really this is an early sign. You can see here that our J point, just where the QRS complex ends and the ST segment begins, there's quite clear elevation there. Now, some people will talk about hyperacute T waves, which can occur before the ST elevation, and that can happen sort of instantly. And that's where the T wave really gets shifted much closer to the QRS complex. But I think in practicality, the chances of you recognizing a patient's having chest pain and them having a 12-lead ECG done within that time scale and only having hyperacute T waves is quite uncommon, so I think it's reasonable to think of ST elevation as being a very early sign here. And then over a period of hours, you tend to develop T wave inversion, so you've still got the ST elevation here, but you've clearly inverted your T waves. And then after about 24 hours, you start to get these Q waves developing, and you can see that that's that first negative deflection in that QRS complex. It's a Q wave because it's a downward deflection before any upward movement. And then you essentially get resolution that can occur over days to weeks, but you'll see that that Q wave remains, and that will be there permanently, although the T wave may well flip back to normal. So I think it's important to talk about where to measure ST elevation from. And essentially, you should measure it from the J point, and that's, as I've said, the junction between the QRS complex and the ST segment. That's what the guidelines say, that's what the 4th definition of myocardial infarction states, although there's no real evidence about the sensitivity and specificity of measuring it at other points. That is where everybody should be measuring it from. And so here we have an ECG, and you can see this is the J point here, just where that QRS complex, that S wave ends, and we move on to the the ST segment there. And the guidelines say that the reference point should be the PR interval at the end, just before the QRS complex. So we can run a bar here between the J point and the reference point, and you can see that actually it's quite significant ST elevation, but it's less significant than using the sort of isoelectric point after that T wave on the far right of the diagram, but it's also more significant than if you'd measured that ST elevation right in the middle of the ST segment where it's a bit lower. So really the reference point is that PR interval just before the QRS complex, and the point to measure the ST elevation is the J point. So why do we get ST elevation? So this occurs in full thickness infarcts, and I think you may remember from the first lecture that the ST segment represents the plateau phase of ventricular muscle cells. And essentially what we have is in a hypoxic or dying region, we have an injury current, often of potassium, leaking out from these dead cells, and that travels away from the site of injury. But when the cells in the heart are all depolarized, there's no potential difference left. So at that plateau phase, the potential difference is essentially zero, so there's no movement of these electrolytes. So that injury current essentially disappears. And as you remember, a current moving towards the lead will lead to an upward deflection, and away from will lead to a negative deflection. So I think what we need to know is that our reference points here, as we've talked about in the previous slide, are our PR interval, and sometimes that interval between the end of the T wave and the beginning of the P wave. And that's what we use, our eyes use as our isoelectric points. And importantly with ST elevation, I know I harp on about this a bit, but really you need to be seeing it in two leads that are next to each other, okay? Because individual leads can have a bit of ST elevation, and if it's just one lead by itself, it's unlikely to be significant. And it's 1 millimeter in the limb leads and 2 millimeters in the chest leads. It's the sort of traditional way of thinking about it. Although, as I said in lecture 1, the newest evidence suggests, or the newest guidelines suggest, that it's 1 millimeter in any of the leads apart from leads V2 and V3, where it needs to be 2 millimeters. So let's get on to why you get ST elevation. So I've drawn this dotted line, which will be our actual isoelectric line. And essentially we have a normal heart here, and we have our ECG lead, and it records our trace. And now we have our heart, and this red region is this area of infarction, and you can see these red arrows coming away from it are our injury current. And when we're repolarized, we're just prior to ventricular depolarization, that injury current is moving away from the lead, so it actually just pushes everything down. So you can see here our PR interval and indeed our P wave are pushed further down away from the isoelectric line. And then the ventricular muscle depolarizes, and as I said, that gets rid of that potential difference, so that injury current stops. And so actually our ST segment is actually at the isoelectric point, because there is no injury current at that point. But because our reference, our PR interval, has been pushed down, we get what appears to be ST elevation. And this is what's happening in an ST elevation myocardial infarction with a full thickness infarct. And then we repolarize again at the end, and again our in this case TP interval is being pushed down because that current is moving away from the lead. So when does it fall down? I think the key thing that I want to get across in this slide is the idea that there are some other situations, other ECG cases where there's no acute pathology necessarily going on, but there may be ST elevation. So this is particularly seen in left bundle branch block, where ST elevation is the norm. And so you can see here's our trace. We'll talk in a later lecture about what makes this left bundle branch block. But you can see here's our reference line. And you can see quite clearly with this red shading here, there's quite profound ST elevation here, even at that J point. But we can also see this in right bundle branch block. We can see it with paced rhythms, which really just end up looking like left bundle branch block And you can see it with left ventricular hypertrophy with strain, when you can get quite significant ST segment deviation. And none of these are necessarily an acute pathology, but they will or can present with significant ST segment deviation. And I think it's just worth bearing these in mind when you think about a patient. I think the key thing with an ST elevation myocardial infarction is normally there is chest pain or quite significant risk factors, and the patient is feeling unwell. And that is not always the case, but that's the majority of cases. So make sure you use the clinical context when interpreting the ECG. So let's go through an example ECG, and I'll use the same format to go through example ECGs throughout this lecture series. And what will happen is I'll bring the ECG up on the screen and I will stop talking for a few seconds. And what I'd suggest you do is pause the lecture at that point and try and go through and interpret it. And then I will go through and interpret it afterwards and highlight some key features of the ECG. But it's really going to be most beneficial for you if you try and interpret it yourself first. So here's our example ECG. Okay, so going through the ECG, what you'll see is I'll put up on the right-hand side the points that I'm talking about at each point. So we don't actually have any details. Hopefully all the ECGs that I've included here have been entirely anonymized. So in terms of the technical aspects, actually, you'll see on that left-hand side that the calibration square or rectangle doesn't look normal in the sense that it's not a full large square wide. In this situation, unfortunately, you just got to ignore it. It just happened to be the quirk of an ECG machine where I was working and collected this ECG from. So how fast are we going? Well, we can see that we've got about 4 large squares between each R wave, so we're probably getting about 75 beats a minute. We can see clear P waves before each QRS complex. The R waves are equally spaced apart and the P waves are positive and lead 2, so we're quite happy that this is sinus rhythm. Cardiac axis here appears to be normal. We've got upward going lead 1 and an upward going lead 2. So P waves appear to be relatively normal morphology, they're not too big. Bearing in mind the size restrictions that we talked about in lecture 1. And the PR interval appears to be normal. I think looking at it, it looks like it's probably about 160 milliseconds, which is bang on normal. And the QRS complex is narrow, so it's less than 3 small squares wide, and it's certainly not overly large. So when we add up the S wave in V1 and the R wave in V6, it's certainly less than our 35 small squares. So ST segment. So hopefully you guys realize that there's quite significant ST segment changes here. I'll blow those up for you, and you can see that there's quite significant ST elevation, particularly in V2 there. And that should be concerning, certainly. So you've got 2 contiguous leads here, both with significant ST elevation. And if we look at the T wave, so I'll blow up another part of the ECG, but you can see quite obviously quite significant T wave inversion, particularly in lead V4, and perhaps a biphasic T wave in V5, but this is obviously not normal. So our summary would be that this is a 12-lead ECG of somebody in sinus rhythm, of which the most obvious abnormality is quite significant anteroseptal ST elevation. That I would be very concerned this person is having an ST elevation myocardial infarction. And so that's what I've suggested our diagnosis is here. Obviously, we need to correlate this with the clinical context. So we've talked a bit about STEMI, and now we're going on to talk about NSTEMIs, non-STEMIs. Remember that stands for non-ST elevation myocardial infarction. And really, I want to talk about the ECG findings for NSTEMIs. So in this case, it's a partial thickness infarct of the heart. And as I said before, that tends to be subendocardial, okay, so the deepest part of the heart muscle. And the findings you can have include ST depression, you can have T wave inversion, or you can have no change at all. Really, the only change you can't have is ST elevation, because that would make it a STEMI. So yeah, as I said, the damage occurs in the subendocardium, and again you get this injury current from this dead tissue, this potassium leaking outwards, but this tends to flow epicardially because that's the easiest route. So why do we get ST depression? Well, it's a similar story to our ST elevation that we talked about before. We use our reference points being our PR interval or the TP interval from the end of the T wave to the beginning of the P wave. And so here's our isoelectric, true isoelectric line. Here's our normal heart with our ECG lead, and you can see our ECG trace with our ST segment being isoelectric as our PR and TP intervals. Now we have our damaged heart. It's having an end-STEMI. It's got a subendocardial infarction, so that red area is just on the inner surface of the heart, just by the endocardium. We've got our injury current, our red arrows coming out towards our lead in this situation. Remember, that's very different from our STEMI, where that whole area was infarcted, and so everything was going away from it. What that does is we've got this current going towards the lead. As you remember, things coming towards the lead to an upward deflection. So we actually artificially raise up our references here with our TP interval and our PR interval. And then while it's depolarized, we don't have any significant potential difference. There's no movement occurrence. So actually, we end up being back at our isoelectric line for our ST segment. But because our references were artificially raised up, we get the appearance of depression. And then when we repolarize again, that reference line is again pushed up by that injury current. So that's why we think we get ST depression. So here we have another example ECG. So I'm going to pop it up on the screen. I'll give you a few seconds to pause the lecture and interpret it for yourself. I apologize in advance for this ECG being a little low quality. As you'll see, it's not on pink paper, and actually we will skip through some of the interpretation relatively quickly just to get to the real meat of things. But here's our ECG, so feel free to pause. Okay, so hopefully you've had a chance to interpret the ECG, and we'll start going through. So we don't have any details about this patient because the ECG has been anonymized. From a technical point of view, this is technically acceptable. You can see at the top left-hand corner that there's actually a little bar that looks like a capital I, and that bar height is used to work out whether how sensitive the ECG is by putting in 1 millivolt, which is what it says right next to that bar, 1 MV, and its width is the paper speed, and actually that appears to be normal. The heart rate, difficult to tell, but it's certainly not going quickly. Rhythm appears to be sinus rhythm. We've got a positive P wave in lead 2. All the P waves are followed by QRS complexes, and the R waves appear equally spaced apart. Cardiac axis is actually abnormal in this situation, so a positive in lead 1, but negative in lead 2, which, as you remember from lecture 1, suggests that we've got left axis deviation here. The P waves appear to be normal morphology. The PR interval is perhaps a little bit long. It's hard to tell without the pink paper, but it's certainly not the key finding that we're looking for here. QRS complexes, well, I think the first thing to note is that there's quite obviously relatively significant Q waves. And I think they're quite clearly seen in leads V2 and V3. I think potentially by the time you get around to V4, there's a very slight upward deflection before the QRS complex, or as the QRS complex begins, and you can see that upward deflection much more clearly in V5 and V6. It's possible that there's Q waves in leads 2 and 3 as well. I think I can't really make out any positive deflection before that big negative QRS complex. So there's signs of widespread Q waves, which is suggestive of quite significant myocardial infarctions in the past, potentially in both the anterior and inferior territories. We will go on to talk about Q waves in a bit more detail towards the end of this lecture. But the rest of the QRS complex is relatively narrow, and it certainly doesn't reach criteria for left ventricular hypertrophy. The ST segments, I don't think they're hugely deviated. I think the key finding here is obviously our T wave inversion. I'm going to blow this up. You can see it in V3, but it's quite pronounced here in V4 to V6. So if I take an isoelectric reference line, you will see, and I think some of you will have picked this up, that there is some minor ST segment elevation, but it probably doesn't reach our criteria for being a STEMI. Certainly V4 is very minor at the J point. V5 and V6 are slightly more, but I really don't think we're in ST segment elevation territory when you compare that to the previous ECG we've shown. But there's obviously quite significant T-wave inversion here. So I think all in all, if we were to summarize this, this is a sinus rhythm ECG of somebody who shows features suggestive of quite significant previous myocardial infarctions with widespread Q waves and quite deep T-wave inversion suggestive of ongoing ischemic changes in keeping with a anterolateral non-ST segment elevation myocardial infarction. So I want to talk very briefly about what are called reciprocal changes, and that's because I think people hear about them and aren't necessarily particularly sure about what they are. And essentially this is finding ST depression in leads that are distinct from the leads with elevation. So you'll have some leads with ST elevation and then a separate territory of leads. So for example, you might have ST elevation in the lateral leads around in V5 and V6, and then you might see ST depression in the inferior leads down in 2, 3 and AVF. And essentially the theory is that this is a mirror effect. So those leads are looking through the inferior portion, in this case, through into the lateral aspect of the heart. And as you can imagine, if it's ST elevation because it's going towards one lead, when you're looking at the lead from the other side, it's going to cause ST depression. So I'm just going to illustrate that idea of reciprocal changes here on our heart model. So imagine you're getting ST elevation in our inferior leads here. You may well see that you get some reciprocal changes with some ST depression in our lateral leads, particularly 1 and AVL. And as you can imagine, if you've got lead 3 here, AVL is almost a mirror image of lead 3. So if you've got ST elevation in lead 3, you're almost certainly going to end up with some degree of ST depression in AVL. And it's really the reciprocal changes are often seen between the inferior and the lateral leads, but it can be seen elsewhere. So what are Q waves? Well, we know that Q waves, I've described them in lecture 1, are this initial downward deflection of the QRS complex that occurs before any upward deflection. And so it's only a Q wave if there's a downward deflection first. If there's an upward deflection followed by a downward deflection, that's an R wave, the upward deflection, followed by an S wave. So that's what a Q wave is, and small Q waves can be normal. We know, for example, that the septum depolarizes from left to right. We'll talk about that in a future lecture, and that can lead to some small septal Q waves that develop in certain leads. But large Q waves are suggestive of something else. And so essentially, if you imagine you've got an area of heart muscle here, and you've got a lead looking at it. And that will show a positive deflection, okay? So heart muscle tends to depolarize from inside to outside, so you'll get a positive deflection here. And you've got another area of myocardium over here, and you've got another lead. And again, it'll show a positive deflection. But if you were to infarct this lateral area of muscle here, that lead that's looking at it isn't going to see any signal from that area of cardiac muscle. That's going to become completely inert, and people describe it as being an electrical window. Okay, so the lead doesn't really recognize there's anything there at all, and so instead is looking at the next part of muscle that it can see, which is this part of the heart, the other side. And as we said, if it's positive in our left-hand lead, our right-hand lead here, it's going to show a negative deflection, and that's all the Q wave is. It's just looking through an isoelectric window at the other side of the heart, depolarizing normally. And so you get this negative deflection. And that's why it happens in myocardial infarctions. So it's this isoelectric window, and it really suggests there's been a degree of transmural tissue death. Because if there's been only partial tissue death of that area of tissue, and there'll still be some electrical signal, and that will reach that lead first, so you'll get a positive deflection initially, so you won't get a Q wave. And really, we say that they're pretty normal if it's less than 1 millimeter wide and less than 2 millimeters deep. Anything more than that is suggestive of something more significant going on, some form of previous infarct, for example. So again, similar to previous lecture, I'll just show you a couple of Q waves. So we've got our very little ones here. They are probably just related to septal depolarization going away from this lead. And here we've got quite significant Q waves. You can see that they're about 4 small squares deep, although they are quite narrow. And that combined with that TO inversion might be suggestive of some ischemic heart disease. So just to wrap up, we'll come towards the end of this lecture, I want to talk about some ischemia mimics. So these are unlike those earlier conditions I talked about where there can be some ST elevation. These are situations that can often present with patients being acutely unwell and can present with ST segment changes, although not all of them. So one is pericarditis. So you get this global saddle-shaped ST elevation, and it doesn't conform to any vascular territory, and the patient will often complain of chest pain. So it needs to be up there in your differentials of chest pain and ECG changes. Another one is benign early repolarization, and often the patient will be completely well, and this will just be an isolated thing that gets picked up. The reason why I put it in here is simply because I think it's really important to know about, because the ECG will otherwise look very normal, as opposed to our left bundle, right bundle branch box that we were talking about before. And this can cause quite widespread ST elevation at the J point, which can be quite worrying until you realise that the patient in front of you is completely well, has no chest pain, is often young and otherwise fit. And so you really do need to take that clinical context into consideration when you're looking at the ECG. Your left ventricular hypertrophy with strain, now I put this in both places, but this can cause quite significant lateral ST depression with T-wave inversion, particularly if the heart rate goes up, if the patient's feeling otherwise unwell, has got a bit of sepsis or anything like that. You can get these quite dynamic changes, which can be quite concerning. And I think that's part of what you should be looking for, is whether these changes are occurring over time or whether they're fixed. You know, if it's left bundle branch block causing ST elevation, then if you do the ECG now and you do it in half an hour, 2 hours, it should be very similar. Whereas if you've got something that's evolving, like a myocardial infarction, then you're going to get changes in those ST segments, changes in those T waves. And the reason to put LVH here as well is simply because actually you can get quite some dynamic change if the patient's unwell with it. Pulmonary emboli can cause quite significant T-wave inversion, particularly anteriorly in those leads V1, V2, V3, which really are looking at almost at that right ventricle. And so T-wave inversion is quite common in pulmonary emboli, and that is worth thinking about, certainly, because it will also present with chest pain. And you can have something called Brugada syndrome, which essentially is an inherited problem with a channel within the heart, and it causes this downsloping ST elevation in the septal segments that can come and go, particularly if people have fevers. This ECG finding can appear, and these people are very liable to sudden cardiac death and may well need an implanted defibrillator fitted. Okay, so talking about ischemia mimics, here is an ECG for you to interpret. I'll give you a few seconds to pause the lecture and go through the ECG. Okay, so hopefully you've had a chance to go through it, and I'll just go through it now and we'll see if we both agree. So no details about the patient on this ECG, but I will tell you that they've presented with some chest pain. Appears to be technically calibrated normally. You can see the little rectangle on the left-hand side of the ECG goes up 2 large squares and across 1 large square, so that's calibrated normally. The heart rate looks to be about 150 beats a minute, so it's going quite quickly. You can see that there's about 2 large squares between each R wave. Rhythm appears to be sinus rhythm, so you've got P waves that are upright in lead 2, and they precede each QRS complex, and the R waves appear to be evenly spaced. Cardiac axis is normal, so we've got positive lead 1, positive lead 2, so it's got to be in that normal section. We've talked about P waves being upright in lead 2, and their morphology appears to be pretty normal, so it's only maybe a square, square and a half high, and a couple of squares across, so perfectly normal P wave morphology. Now the PR interval is not prolonged or too short. It looks pretty normal duration, but you may notice, particularly if you look at, say, lead 2, that there appears to be some PR depression. That P wave is lower than the interval between the end of the T wave and the beginning of the next P wave, and you can certainly see that in lead 2. QRS complexes appear to be narrow. They don't particularly appear to be very large. I mean, you're potentially getting towards LVH criteria with V1 and V6, but I think we're still at about 30 small squares, so we're probably just under it. That's something to bear in mind. Now, ST segments, they look a bit unusual, don't they? I think there is some ST elevation there. Let me pull out some of these ones here. So we've got lead 2 on the left, so some inferior stuff. We've got an anterior lead in the middle, and we've got a lateral lead on that right-hand side. And I'll put a bar through here on our PR interval as our reference point. You can see quite significant S2 segment elevation, the same here and the same here. So that's quite interesting. And actually, particularly in leads 2 and V5 here, you can see that that ST segment is not flat. It looks like a little cup, a little saddle. Yeah. And so that's what you should be thinking about. So you've got this widespread ST segment elevation, so it doesn't fit with any vascular territory. You've got this saddle shape, and you don't have any T wave inversion, okay, which is unusual in in infarction. So as we said, T waves appear to be upright, but appear to be pretty normal. So in summary, we've got a patient who's got a sinus tachycardia, going at 150 beats a minute, who has widespread ST segment elevation with some PR depression, and the ST segments appear to be saddle shaped. So I think this is most in keeping with acute pericarditis. Okay, so let's give you one more before we finish off today. So here's our ECG again. I'll give you another few seconds to pause the lecture and go through it. Okay, so hopefully you've had a chance to go through it. So no details again. I'll tell you this was just a routine ECG that I picked up when I was an orthopedic F1. From a technical point of view, I don't have a calibration strip here, but it appears to be technically pretty normal. Heart rate wise, we've got it going about 5 large squares between heartbeats, so we're going at 60 beats a minute. The rhythm appears to be normal. We've got equal distances between each of the R waves. We've got a P wave preceding each QRS complex, and the P wave is positive in lead 2. Cardiac axis is normal. The QRS complex is positive in leads 1 and 2. The P wave morphology appears to be all right. I think some of you might have picked up there appears to be a slight bifid character to the P wave in lead 2. Appears to be a couple of humps to it, but actually it's not that wide, and I don't think that this is P martrale. Okay, because although it has a slightly unusual characteristic, it doesn't look big. PR interval appears to be probably at the upper limit of normal. It's about 200 milliseconds. The QRS complex is narrow, and the amplitude is not significant to suggest LV hypertrophy. But our ST segments look pretty weird, right? There's some pretty weird ST segments, particularly in V1 and V2. I'll make this a bit bigger for you. Here's our reference point, and you can see really that J point is very elevated. But you've got this down-sloping ST elevation, really is coming almost straight down and then going straight into an inverted T wave. And that again doesn't look like that ST elevation that I showed you previously on another ECG. And if you go back at the end of the lecture and compare them, I think that is worth doing just to get an idea of how they are quite so different. You have this T wave inversion here, and this is in the septal leads. So we've talked about the T waves, we've got this anterior T wave inversion. So in summary, we've got an incidental finding of downsloping ST elevation in the anterior leads. And I wouldn't be surprised if you haven't got this, that's absolutely fine. This is an ECG that's very typical for Brugada syndrome. And you may see this if you do an A&E job. People can come in with a fever and suddenly get these ECG findings they don't otherwise have. And it is something to take note of. And I think this is one of those pattern recognition things that V2, particularly in this case, is absolutely classic for Brugada syndrome. So that's getting to the end of the lecture here. So I'm just going to recap through our learning objectives, make sure that we've covered everything that we wanted to. So we've gone through the vascular territories and how those relate to our ECG. So we've got our anterior and septal territories, we've got our lateral and inferior territories. We've talked about the timescale of ischemic changes, particularly in ST elevation, myocardial infarctions. We've recognized and discussed those ECG features. So for ST elevation, myocardial infarctions, it's obviously ST elevation you're looking for. For our non-STEMIs, it's either a normal ECG or ST depression or T wave inversion, or occasionally ST segment elevation that doesn't meet the criteria for a STEMI. We've talked about why those changes can occur. We've talked about what Q waves are and their pathological significance and how they're quite different from those small physiological Q waves that you can see in some leads. And we've talked about some quite common ischemic mimics on ECG, particularly pericarditis. It's very common and should be remembered. So again, end of the lecture, I normally ask the questions, but feel free to either drop me an email or touch base with me on Twitter. Very happy to discuss any questions you might have. I can't guarantee I'll have the answers, but I can either point you in the direction of somebody else who does, or a resource that will, or I can find out for you. So I very much hope that you've enjoyed this lecture, and hopefully I'll see you for lecture 3.